It's 2:00 a.m.
That's the worst time.
Right. The house is pitch black, everyone else is asleep, the dog, the neighbors, literally the rest of the world. But you're standing there, you're leaning over a crib or a toddler bed, and you're just staring at your child's chest rising and falling.
Yep.
And you're listening to a sound that just doesn't sit right. Maybe it's a wheeze. Maybe this sounds like a barking seal. And in that total silence, your brain just instantly goes to the darkest possible place. Is this just a regular cold, or are we 10 minutes away from an ambulance ride to the ER?
That's the universal parenting nightmare right there, the 2:00 a.m. panic. I mean, it's a very specific kind of loneliness, isn't it? You feel like you're the only person awake on the entire planet, and you're trying to diagnose a potential medical emergency with, nothing but a thermometer, a dim nightlight, and your own skyrocketing anxiety.
That is exactly where we are starting today. We are doing a deep dive into an incredibly thorough guide, the ultimate parent's guide to respiratory season. And we aren't just talking about sniffles here.
No, definitely not.
This isn't about chicken soup and warm, fuzzy feelings. The sources we're looking at today are designed to turn that midnight panic into actual data. We are talking about a tactical, medical-grade cheat sheet for American families surviving the winter months.
Right. The whole mission of this deep dive is to move you from panicked guessing to informed observation. We want to give you the tools to decode the noises, the visual signs, and the timelines, so you know exactly when you can just make some tea and write it out, and when you need to get the kid in the car.
And we have a lot of ground to cover. We're going to break down the anatomy of a cough, all the way from the throat, down the windpipe, and deep into the lungs. We'll get into the strep paradox, the actual physics of croup, the day 3 trap of RSV, and walking pneumonia. But let's just start at the top, the throat audit.
The throat audit, because that's where everything usually begins. The child complains it hurts to swallow, or maybe they just completely refuse to eat dinner.
And here's the first stat from the source material that really hit me hard. 80% of sore throats in kids are viral. Rhinovirus, adenovirus, the flu. As a parent, my immediate instinct when I see my kid in pain is, get me the antibiotics.
Oh, absolutely. Give me the magic pink liquid.
Yes. But the data says that for 8 out of 10 kids, that prescription is totally useless.
Completely useless. And actually worse than useless because of potential side effects, disrupting the gut biome and contributing to antibiotic resistance. But the key medical takeaway here isn't just memorizing that 80% stat, it's knowing how to actually spot the 80%. The sources describe a viral throat as being noisy.
Noisy, like the kid is crying and complaining a lot.
No, noisy in terms of the clinical presentation of symptoms. A viral infection is essentially a systemic party. It's never just the throat. You've got the runny nose, the postnasal drip, the cough, maybe they have pink eye, a hoarse voice. It's a whole mess of things at once. And usually the fever is on the lower side. We're talking below 101.3 degrees Fahrenheit.
Okay, so if my kid is coughing, super snotty, and complaining their throat is on fire, I should actually take a breath and be relieved, because all that extra stuff points to a virus.
Counterintuitively, yes. That clinical noise suggests it's not the severe bacteria we're so worried about. It means the body's immune system is fighting off a widespread viral invader.
Okay, so if we're in that 80% viral bucket, the guide pivots to supportive care. And I was actually really surprised to see honey listed as a serious medical recommendation. I always thought that was just, an old wives' tale.
It's highly evidence-based. Physiologically, honey acts as a demulcent. It physically coats the mucous membranes in the throat and soothes that raw irritation. Plus, it has mild antioxidant properties. The guide actually notes it can be just as effective as some over-the-counter cough suppressants like dextromethorphan for calming down a nighttime cough.
But there is a massive red flashing warning light here that we absolutely need to mention.
Yes, a critical medical warning. Never give honey to a child under 1 year old.
Because of infant botulism.
Exactly. Their intestinal tracts just aren't mature enough to handle the Clostridium botulinum spores that can naturally occur in honey. If those spores germinate in an infant's gut, it leads to paralysis. It's rare, but it is incredibly dangerous.
Right. So under 1 year old, absolutely zero honey. Over 1, it's liquid gold. Now let's flip the coin. If 80% is viral, I'm stressing about the other 20%. The silent killer, Group A strep.
And this is where we get into what we call the strep paradox. If a viral throat is a noisy party of a bunch of different symptoms, strep is often defined by what is missing.
And what's missing is the cough.
The cough.
Yeah.
This is the single biggest clinical differentiator the sources highlight. Strep is a specific bacteria that sets up shop strictly in the tonsils and the throat tissues. It doesn't usually migrate down to mess with the lungs or up into the nasal passages. So you get a sudden, really high fever boom, over 101.3 Fahrenheit and extreme throat pain, but the child is not coughing.
That is such a huge tell. No cough, sudden high fever. And the guy says we need to actually look inside the mouth, which I admit I'm usually way too squeamish to do, or I just don't even know what I'm looking at.
You have to look. You need to become very comfortable wielding a flashlight. With strep, you are looking for angry, inflamed red tissue. You'll see swollen tonsils, often with thick white or yellow patches of pus. And there's a very specific visual sign called petechiae.
Petechiae. Break that down for us. What does that look like?
They are these tiny, bright red dots on the roof of the mouth, specifically way back on the soft palate. They look like little pinpricks of blood. Physiologically, that happens because the strep bacteria releases toxins that actually cause tiny capillaries to burst. So if you see those red ducts, plus the pus patches, plus a high fever, and there's no cough, that is a very high clinical probability of strep.
The guide also mentions something called a center score. Is this something an average parent can calculate at home, or is it strictly for pediatricians?
It's a clinical diagnostic tool, but parents can absolutely use it to gauge the urgency of the situation. It's a very simple point system. You give 1 point for fever, 1 point for swollen lymph nodes in the neck, those tender bumps right under the jawline, 1 point if you see pus on the tonsils, 1 point if the child is between the ages of 3 and 14, and this is crucial, 1 point for the absence of a cough.
So if my kid scores a 4 or a 5 on that scale, we aren't just waiting it out with popsicles and cartoons.
Definitely not. That is a mandatory trip to the doctor for a throat swab. And this really matters because strep isn't just a bad sore throat. The guide is incredibly clear on the severe complications here. If you let group A strep run wild untreated, the immune system can essentially get confused and attack the body's own tissues, triggering rheumatic fever.
Which permanently damages the heart, right?
Yeah, exactly. It can permanently scar the heart valves. It can also cause severe kidney inflammation, which is known clinically as glomerulonephritis. That's exactly why antibiotics are non-negotiable for strep. You aren't just treating the temporary pain, you're actively preventing long-term, irreversible organ damage.
Okay, that makes perfect sense.
Yeah.
Clear distinction: viral is noisy and cough-heavy. Strep is silent, hot, and localized. Now, let's move further down the airway. We're dropping into the windpipe, and we're talking about the specific sound that I think scares parents more than anything else in the world. Croup.
The bark in the night?
It's always at night. Seriously, why does it always happen at night?
It's actually a physiological combination of things. Cortisol levels, which act as our body's natural anti-inflammatory, naturally drop at night. Plus, just the act of lying flat changes the fluid dynamics and blood pooling in the upper airway. But you're right, that sound, that seal-like barking cough, it's absolutely terrifying because it sounds like the child's airway is physically closing.
But is it?
Well, sort of. To really understand croup, you have to look at the anatomy. It's usually caused by the parainfluenza virus. And this particular virus loves to attack the subglottic area. That's the rigid, circular ring of cartilage sitting directly below your vocal cords.
Which is the narrowest part of a kid's airway to begin with.
Precisely. Now think about the physics of a garden hose. If you put your thumb over the end of the hose, the water sprays out way faster and makes a loud hissing noise. That's turbulence. In a toddler's tiny little windpipe, just 1 single millimeter of swelling cuts the total airflow area by 50%.
Wow. 50% from just 1 millimeter of swelling. That completely explains the crazy noise.
The physics of small tubes is incredibly unforgiving. So when the air tries to force its way squeeze through that swollen, inflamed ring of cartilage, it creates that harsh barking sound. And if it gets tight enough, that's when you hear stridor.
Stridor. That's the high-pitched gasping squeak when they are breathing in, right?
Yes. A wheeze is typically heard when breathing out. Stridor is when they are breathing in. It sounds like a really high-pitched squeak or a desperate gasp. The guide highlights something called the steeple sign here, which is the classic visual doctors look for on a chest x-ray.
The steeple sign. What does that look like?
Basically, the normally wide column of the airway narrows to a sharp point at the top, looking exactly like a church steeple instead of a nice wide open tube. It's a very stark visual diagnostic for severe swelling.
That visual is haunting. So let's play out the scenario. It's 2:00 a.m. My kid wakes up barking like a literal seal. I hear that high-pitched rasp on the inhale. Do I call 911 immediately?
Yeah, necessarily. And this is where the triage section of the source material is so brilliant. You have to clearly distinguish between mild and severe croup. In a mild case, you might hear that stridor, but only when the kid is upset or actively crying.
Okay. So when they finally calm down, the squeaking noise stops.
Right. And that leads to the absolute most important treatment strategy for mild croup, which is purely psychological. You have to keep them calm. If they cry, their body demands more oxygen. If they need more oxygen, they breathe faster and harder. That creates more turbulence, more swelling, more noise, and then they panic more. It's a vicious, escalating feedback loop.
So at 3:00 a.m., we are doing whatever it takes. iPad, cartoons, popsicles.
Anything goes. Screen time rules completely go out the window. Cold air is also a massive physiological help. Wrapping them in a warm blanket and just stepping out onto the porch into the cold night air. The cold actually constricts the blood vessels in the airway and can shrink that swollen tissue just enough to break the cycle.
But when does it cross the line into an emergency? When do I need to turn off the iPad and start the car?
You go to the ER if you hear that stridor while they are completely at rest. If they are lying totally still on the couch watching a cartoon and you can still hear that high-pitched rasping on every single breath, that means the airway is critically narrow even without exertion. That is a go-now situation.
And what about retractions? That medical term comes up a lot in these sources.
Retractions are the ultimate visual sign of increased work of breathing. It's pure physics again. The lungs are desperately trying to pull air in against a severe blockage. It creates a vacuum effect in the chest cavity, so the soft tissue gets physically sucked inward. You'll see it at the little notch at the base of the neck, right above the collarbone, or the skin visibly sucking in between the ribs.
Almost like they're being vacuum-packed with every breath.
Exactly like that. If you see retractions, especially while the child is resting, you head straight to the ER.
And once we get to the ER, the guide mentions they pull out the big guns. Nebulized epinephrine, that sounds really intense, giving a toddler straight adrenaline.
It is intense, but it is incredibly effective. The epinephrine forcefully constricts the swollen blood vessels in the airway almost instantly. The clinical relief is visible in minutes. You watch the child go from gasping for life to breathing completely normally. But, and this is a massive but that the guide emphasizes, there is a rebound warning.
Meaning the swelling just comes right back.
It absolutely can. The epinephrine acts incredibly fast, but it gets metabolized and wears off after a few hours. When it does, the blood vessels can dilate again and the swelling can rebound, sometimes even worse than it was before the treatment. That's why if your child gets a breathing treatment in the ER, you are not going home immediately. You are staying right there for 3 to 4 hours of strict clinical observation.
That is really vital to know, so don't argue with the doctors when they won't discharge you at 4 a.m.
Never. You want to be sitting in a hospital bed if that rebound happens, not strapped in a car seat on the highway or back asleep in your house.
Okay, let's go even deeper. We're moving past the throat, past the windpipe. We are entering the deep lungs. This is what the guide calls the mucus war. We're talking about RSV and bronchiolitis.
RSV, respiratory syncytial virus. It is the undisputed heavyweight champion of infant hospitalizations in the U.S.
Why does this specific virus hit babies so incredibly hard compared to older kids?
It's all about geography and anatomy. Croup is an upper airway disease. RSV attacks the bronchioles. Those are the tiniest microscopic airway branches at the very bottom of the lung structure.
And the actual mechanism of the disease is different too, right? It's not just cartilage swelling like croup.
No, it's cellular debris. RSV literally causes the epithelial cells lining those tiny airways to die and slough off. And simultaneously, it triggers a massive inflammatory response with huge amounts of mucus production. So you end up with dead cells and incredibly thick snot, completely clogging up tubes that are already only the width of a human hair.
Sloughing off. That is such a disturbing, visceral image. It's like a logjam in a tiny river.
A logjam is the perfect medical analogy. Air can get into the lungs because you actively use your diaphragm muscles to inhale and pull it in, but it passively can't get back out past that sticky mucus plug. That clinical phenomenon is called air trapping. The baby has to work incredibly hard just to push the air out. That's exactly why you hear the wheezing sound.
The guide points out a very specific timeline here, which it calls the deceptive timeline. I feel like this traps so many parents into a false sense of security.
It trips people up constantly. Days 1 through 3 of RSV look exactly like a mild common cold. Runny nose, maybe a flight fever. You think to yourself, oh, we're managing this just fine. But the pathophysiology of RSV dictates that the mucus buildup peaks on days 3 through 5. That is the true danger zone.
So literally just when you think you're out of the woods, the breathing issues spike.
Correct. The mucus reaches critical mass, so on day 4, you need to be hypervigilant. And the guide gives us a very specific, practical tool for this, the counting technique.
Walk us through this exactly, because saying a baby is breathing fast feels really subjective. My version of fast might be very different from your version of fast.
It absolutely cannot be subjective. You need hard data. You strip the child down to their diaper so you have a clear view of their bare chest and belly. You wait until they are completely calm, they cannot be crying, and they shouldn't be actively feeding. And you count every single breath for a full 60 seconds.
Can I just count for 15 seconds and do the math? Multiply by 4.
Absolutely not. Babies have what's called periodic breathing. They'll breathe really fast for 10 seconds, then slow down, then maybe even pause for a couple of seconds. You need the true average over a full, uninterrupted minute.
And what are the actual danger thresholds we're looking for?
According to the World Health Organization guidelines cited in our source for a baby under 2 months old, anything over 60 breaths per minute is a major red flag. That is literally 1 breath every single second.
That is incredibly fast for a resting baby.
It is exhausting. For a baby between 2 and 11 months, the danger limit is 50 breaths a minute. And for kids 1 to 5 years old, it's 40. If your child hits those numbers, their body is essentially running a marathon while lying in a crib. They will inevitably tire out, and when an infant's respiratory muscles tire out, they just stop breathing. That is clinical respiratory failure.
That's terrifying. Just genuinely scary. But the guide does offer some major hope on this front. There's been a massive medical breakthrough recently with RSV prevention, right?
Huge game-changing breakthroughs. We finally have actual shields against this virus. For pregnant mothers, there's now an RSV vaccine that is given between weeks 32 and 36 of pregnancy. It allows the mother to generate antibodies and pass them right through the placenta, so the baby is actually born with active protection.
And what about for the babies themselves if the mom didn't get it?
There's a treatment called nirsevimab. It is a monoclonal antibody shot. It's important to note it's not a traditional vaccine that teaches the baby's body to fight. It actually is the fight. It provides an instant army of antibodies. The clinical data shows it cuts the risk of infant hospitalization from RSV by over 80%.
80%. That is just a complete game changer. If you have an infant born in the winter, you absolutely need to ask your pediatrician about that shot. Okay, we've done the upper airway, we've done the bronchioles. Now we are into the deep invasion, pneumonia.
Right. Pneumonia is where the bacterial or viral infection reaches the actual air sacs themselves, the alveoli. And instead of being filled with oxygen, these tiny balloons fill up with inflammatory fluid or actual pus.
The guide splits this into 2 distinct categories, typical and walking pneumonia. I've obviously heard the term walking pneumonia before, but I always just assumed it meant it wasn't a real infection, like a mild cold.
Not exactly. There are very distinct clinical pathways. Typical pneumonia is usually bacterial, most commonly caused by Streptococcus pneumonia. It hits the body hard and fast, sudden high fever, shaking chills, deep chest pain, and a very productive cough. You can literally hear the gunk rattling deep in their chest.
And walking pneumonia.
That's usually caused by an atypical bug called mycoplasma. It's much sneakier. It's very common in school-aged kids, ages 5 to 15. The onset is incredibly slow. The kid might just seem unusually tired with a dry, hacking, lingering cough that just won't go away for weeks. They aren't bedridden, hence they're walking around, but their lung function is significantly compromised.
And sometimes they get a strange rash with that one, right?
Yes, a diffuse rash can appear in about 10 to 25% of those cases. It's a weird systemic immune reaction to the mycoplasma bacteria.
Now, the guide gets very serious, almost militant, about antibiotics in this section. It says finishing the entire course is non-negotiable. I feel like we hear doctors say that all the time, but why is it so hypocritical specifically for pneumonia?
Because the physiological complications of untreated or partially treated bacterial pneumonia are straight out of a medical horror movie. The bacteria can physically destroy the lung tissue.
Destroy it how? What does that mean?
You can develop what's called necrotizing pneumonia, where the lung tissue actually dies, liquefies, and rots. Or an abscess, which is a thick-walled cavity inside the lung completely filled with pus. Or something called empyema.
Empyema. That sounds ancient and terrible.
It is terrible. It's when the infection literally spills out of the lung itself and thick pus fills up the pleural space, which is the physical gap between the outside of the lung and the inside of the chest wall. That doesn't just clear up with a stronger pill. It often requires invasive surgery or a chest tube inserted through the ribs to physically drain the pus out.
Okay, message absolutely received. If the pediatrician prescribes amoxicillin for typical or azithromycin for walking pneumonia, we take every single pill in that bottle, even if the kid is doing cartwheels in the living room on day 3.
Precisely. You have to eradicate the bacteria completely so it doesn't retreat, mutate, and regroup into a resistant superinfection.
We've covered all the major diseases now. The guide ends with a really fascinating section on what it calls building the fortress, prevention. And it starts with something I honestly didn't expect to see in a standard respiratory medical guide: pollution.
It's the invisible enemy of pediatric pulmonology, specifically particulate matter 2.5 or PM 2.5.
These are the tiny particles in the air from smog or smoke, right?
They are microscopic, literally 1/30th the width of a human hair. Because they're so incredibly small, they don't just get breathed in and sit in the lungs, they actually bypass the lungs' defenses and cross the alveolar barrier directly into the child's bloodstream.
And for a kid with actively developing lungs.
It's highly toxic. It causes a state of chronic, low-grade inflammation. It fundamentally weakens the local immune macrophages in the airway. So when a respiratory virus finally does show up at the door, the immune system is already exhausted and the door is practically unlocked.
So what do we practically do about that? We can't control the weather or the city smog.
We can't, but we can completely control the indoor environment. You need to be checking the air quality index apps on your phone. If the AQI is bad outside, you skip the park and play inside. Use true HEPA filters in the child's bedroom. And the medical guide is militant about this rule: zero smoking indoors, ever. Even third-hand smoke, the invisible chemical residue that sticks to jackets, car seats, and furniture, is enough to chronically irritate a toddler's fragile airway.
Then there's the immunity menu. I found the nutritional stats in this section completely shocking.
They are alarming for a developed country. The source cites clinical data showing that up to 60% of kids might be zinc deficient, and 1 in 3 could be clinically iron deficient.
Why does that matter so much for fighting off a basic cold?
Think of iron as the basic logistics supply chain for your immune army. It is physiologically crucial for the creation and maturation of T cells, the white blood cells that actually hunt down and kill viruses. If your child is low on iron, their immune army is severely understaffed. And zinc. Zinc is the chemical spark plug. It catalyzes over 300 different enzyme reactions in the body, many of them strictly dedicated to the immune response.
So we're talking about feeding them beef, eggs, nuts, shellfish.
Real bioavailable food sources are always best. The human body absorbs iron from red meat, which is heme iron, much, much better than it absorbs non-heme iron from plants like spinach. You can use supplements if a pediatrician runs blood work and mandates it, but a piece of steak or a scrambled egg is a far superior natural delivery system than a sugary gummy vitamin.
Finally, the guide talks about a concept called cocooning. Relive this imagery.
It's a beautiful, incredibly effective public health concept. We so often think of immunity as something that exclusively exists inside the child's own body. But for a vulnerable newborn, their primary immunity is actually the people physically surrounding them.
Because they literally can't get most vaccines yet.
Exactly. You can't give a flu shot to a 2-week-old baby. Their immune system simply isn't developed enough to process it. So you vaccinate the parents, the grandparents, the babysitter, everyone. Everyone gets their flu shot, their Tdap booster for pertussis, their COVID shot. You intentionally form a protective biological shield, a cocoon, so the virus physically cannot find a host to reach the infant in the middle.
It really shifts the entire perspective.
Wow.
We, the adults, are the environment.
We absolutely are. The filtered air in the house, the iron-rich food on the dinner table, and the active antibodies floating in our own bloodstreams. Collectively, that is the child's true immune system for the first few months of life.
That is such a powerful place to leave it. We've gone from the terrifying 2.0 AM bark of croup to the silent, feverish danger of strep, the mucus trap of RSV, and finally to the biological fortress we have to build around our kids.
It all comes back to empowerment through medical literacy. Panic always comes from the unknown. When you hear a weird cough in the dark and just think, my kid is in danger, that's raw panic. When you hear that exact same cough and think, okay, That's inspiratory stridor, but he's calm right now, so I'll just strip him down and count his respiratory rate that is taking control.
And knowing the actual clinical math helps so much. The day 3 to 5 rule for RSV, the 60 breaths a minute threshold for newborns, these are the tangible tools you need to keep in your back pocket for that inevitable 2.0 a.m. wake-up call.
Exactly. Stay observant, rely on the data, and stay calm.
And I'll leave you with one last provocative thought that builds on this whole idea of the environment. If the air we breathe and the food we eat shape our lung immunity, think about the gut microbiome. We talked about antibiotics wiping it out earlier. The latest science is starting to show a massive connection between the bacteria in our gut and the immunity in our lungs, the gut-lung axis. What if the key to surviving respiratory season next year actually starts with healing the gut this year? Something to chew on. Thanks for joining us on this deep dive. Hopefully you'll sleep a little better tonight knowing exactly what to listen for. Catch you next time.